Good afternoon, everyone. My name is Shannon Kupka. I'm a project manager working with the nursing home teams in New Mexico from CoMagin Health. I'd like to welcome you to our half-hour Hot Topics series. These webinars are designed to provide you great ideas on dementia care, behavioral health, and antipsychotic reduction strategies in a 30-minute time frame to accommodate your busy schedules. They're brought to you by CoMagin Health, formerly your Qualis and Health Insight teams, from Idaho, Nevada, New Mexico, Oregon, Utah, and Washington, and sponsored by the New Mexico Healthcare Association and CoMagin Health. We are very excited about today's presenter on working as a team, implementing person-centered care for behavioral and psychological symptoms of distress to reduce pharmacological interventions. Dr. Harry Krulewitch, MD, MPH, is a medical director for a number of skilled nursing, intermediate care, and memory unit residential care facilities in Portland, Oregon. He is assistant professor in the Department of Family Medicine at Oregon Health and Sciences University and is board certified in geriatrics. He is the past president of the Oregon Geriatric Society. He worked from 1993 to 2001 as the geriatrician for the Providence Portland PACE site and has worked as a geriatrician in private practice since 2001. I will now turn things over to Dr. Krulewitch. Dr. Krulewitch, you may get started.
Okay, well, good afternoon, everyone. This is quite a significant topic to cover in 30 minutes, and I'm going to break it down into just a few little pieces. Working as a team, implementing person-centered care to reduce pharmacological interventions for individuals. Really want to focus today on what that means and just specifically what's the philosophy of person-centered care with patients that are struggling with these problems, and what does that mean for the teams and how the teams can approach that issue that may be different than what we're doing. I really want to acknowledge that a lot of the material on these slides that I came up with in just the last few weeks have been based on my attending symposiums with Dr. Powers, who's a leader in this field as a geriatrician, and at the National AMDA Conference in Atlanta and in Portland at the American Geriatric Society, where Dr. Barbara Resnick presented her work on patient-centered care in dementia units. And I'm really summarizing a lot of their work along with my work at OHSU. I teach the family doctors chronic disease management with an emphasis in geropsychiatry on patient preferences and person-centered care and how to guide those discussions. So I've integrated a lot of my work with theirs as we try to run through this material. So we look at today's topic, and this was an outline. This is probably enough for a whole course. We'll try and get it into 30 minutes, but I really just want to focus the first 10 minutes on philosophy. What does it mean? Because I can tell you I've lived long enough that I've heard public health, community health, holistic health, whole person care, whole-centered care, person-centered care, and eventually all of these terms get mashed into different things. So I want to give you an idea of what it means to me, and hopefully that will mean something to you. And then talk about how these scholars that I've worked with are looking at research projects to integrate this model and just take the very first step in what would be a full curriculum. And I trust that your presenters here and this organization is going to give you the other steps as we go along the way. So I'm not going to try and walk through all of the steps. The strategies today will focus on just what the social ecology model is for person-centered care, what type of leadership is required, and what maybe a few models might look like, and what the next steps are in a full curriculum if you were to try and create a model like this for your programs. So these are the steps that Dr. Resnick outlined in her model, and it's very well organized, and I've included this at the end of our show in a resource that she's made available for free on a website that walks people in depth through all of these steps. But we see today we're just going to focus on the first two, philosophy and system integration. But trust me, the much more difficult work are the next five. What's the evidence? What are the tools you can use in your teams? How do you go through clinical decision-making algorithms? How do you apply a care plan with your team? How do you interact on the floor? And then for those rare cases where we all know day-to-day there's going to be severe delirium and agitation, violent and inappropriate behavior, how do you respond to those situations, even with this model? So I think those are all the steps. I didn't want people to think I'm skipping any of them. I'm not going to cover the last five because that's going to be the opportunity for the presenters here to give you more coursework as we go ahead. So let's dive into the philosophy. We all know, and I'm not going to provide the slides, that millions of Americans are aging and a huge percentage have dementia. Easily over 10 to 15 million people with dementia are anticipated by 2030 to 2050, and the numbers vary, but they're in 10 to 15 million numbers range. And it's a huge crisis that we're facing in the aging community. What we're looking at this point are a wide variety of institutional ways to house people, and within that framework, to care for them with a medical model. What's happening is that you are all aware of the fact that this is not a satisfying way to care for these people. The families know that, and professionals are recognizing that it's not the most dignified way to care for people with chronic brain disease. Patient, or we call person-centered care, has so many different definitions. All of the definitions that I found include issues of having the human person's preferences, their goals of care identified and integrated with evidence-based guidelines. That process requires some type of collaboration. What I wanted to share today is how the American Geriatric Society, IHI, and the Hartford Foundation are taking this very complex and diverse set of definitions and coming up with a model called the 4M model of person-centered care that easily explains it to lay people and to our professional staff so we can all be working on the same components with the same general understanding. And then, of course, looking at what that actually means. Person-centered care is really about agency. How do we move from a model of care that's completely determined by the best medical practice and best research, which is a biological medical model, and integrate what our patients and families want, where they actually have a sense of control. This is not an easy process for doctors or management, because we're all used to having control over the process. So how do we create models? Those models are up in the air right now. I can tell you there's many different diverse issues around how you integrate decision-making when it's no longer under the complete control of the professional or the executive team of the place where they're living. Let's see. Whoop.
Click now.
Okay. So I want to get to my. Okay, great. So, you know, the medical model is failing. So I'm just going to try to touch base on that for a second. There we go. Okay, just to highlight it, although I didn't want to go into the epidemiology, I'm sure we all understand that we're dealing with a rising population of elderly people and a huge population in that group that have cognitive impairment. Just looking at what's happening to the medical model in general, without focusing on the dementia patient, we've got problems with the medical model. And we're seeing at every workshop I go to around the country, physicians who are not geriatricians equally concerned with what's happening. First off, it's a very fragmented system that we're dealing with. Second, that the hospital, the nursing home, and the memory unit are not promoting any of the elements of person-centered care when it comes to preference, choice, agency, leading to problems in dignity and compassion. Nearly 90% of every patient that has dementia will at some point during the lifetime of their disease have serious BPSD, behavioral problems of dementia. And those are tagged into areas of anxiety, agitation, apathy, depression, delusions, restlessness, or inappropriate behaviors. Those categories are easily understandable by your staff and by the families so that care plans can evolve in that, in addressing those issues. The problem is, if everyone's that we see are having these issues, how do we change from a medical treatment model? Medical treatment focuses on reducing symptoms. That means some type of restraint. It's either going to be chemical or physical. Hopefully, we've eliminated physical restraint from our memory units, and our state agencies are supervising and surveying people to make sure that's not happening. As most of you know, the survey teams are also very aggressively looking at medication restraint. But even under proper use of medication, it is fundamentally a restraint. We're sedating someone to reduce the symptom. We're not looking at the underlying issues. Well, not only are we sedating the patient, but now we're realizing that these drugs are causing weakness, aspiration, hospitalization for pneumonia, further isolation from immobility, and then eventually are actually increasing morbidity and death for these patients. The 4M model says basically that whatever type of care plan we have, even if it's evidence-based, needs to begin to look at these elements, whether we're doing research, education, care planning, or program development. And the 4 M's of person-centered care first have to do with mobility. Is the person able to move around, not just physically, but emotionally? Is it a satisfying environment? Are they free of falls? And if they're at a fall risk, are we encouraging them to move rather than restricting them so that we don't have them fall? Just like a physical and emotional and chemical restraint, the focus here on mobility is to enhance their function rather than to reduce the risk of falling. Mind has to do with what we're going to be talking about today, maintaining and protecting their mental function. And in general geriatrics, it might not even be creating a person-centered environment, but what are all the other things that lead to proper mental health, social health, and emotional health? And we're not going to cover that today, but mind looks at all of those issues. Medications is now up in the list of the top 4 because we're now recognizing that everything we're doing has major side effects. And medications are the major contributor to a lot of the symptoms our patients are struggling with, even as we try to treat the diseases that they're also suffering with, which is a very complex issue. And I'm proud to say that physicians all over the country are recognizing this. 10 years ago, you couldn't find a single lecture on polypharmacy, and now every single geriatric program in the country has 3, 4, 5 workshops on deprescribing and polypharmacy, not just the neuropsychiatry programs. But the most important issue up there is the 4th M, what matters. We're looking at what are the patient's goals of care, what are their values, what are their preferences, and is the process promoting a sense of agency so that as you deal with mobility, mind, and medication, are we creating a system that fosters their participation as human beings that have some sense of dignity and purpose in what they're doing, or are we just prescribing and treating them as patients to be cared for in our more traditional medical model? If you look at the impact of the medical model on dementia patients, after we just talked about the 4M approach, you can see what some of the real problems are to highlight again. First off, by focusing on people's symptoms, we're characterizing these human beings as having a series of endless losses, which ends up treating them as victims with no sense of whether or not they have any capacity as human beings for any social or emotional interaction. The care plans are institutionalized as disease-based treatments, and that's how we're evaluating them. By focusing on the deficit, we may be minimizing their own capacity to respond in any way that can maintain their own sense of participation and dignity. And if this happens systematically over a period of time, we end up labeling these human beings as patients with diseases rather than as human beings still trying to live with a chronic problem. And we view their situation as fundamentally being a result of brain cellular pathology that should only be responded to with pharmacological interventions. And while we will do this as doctors in our sleep, I trust you to know we do that. If we don't focus on the other issues, we may be avoiding many other approaches that can be helpful. Dr. Powers, who's been teaching us to reconsider the pharmacological management of patients with behavioral problems and dementia, has this simple definition, which is a shift in the way a person experiences the world around them. That may seem very simplistic, but given how aggressively we respond to the medical model, something simple and straightforward like this is basically saying, how do you approach this human being beyond pharmacological management and include that in your definition of dementia rather than defining it as a disease? In his approach and in what I teach the family physicians in Oregon. I still expect them to apply the medical model. I'm not suggesting in any way that you tell your nurses and doctors and nurse practitioners to create a humane environment that negates, ignores, or defies traditional medical care. And we're still going to apply environmental models, whether it's a neighborhood system or models of social interaction that reduce triggers and improve the humane setting. But the greatest distress these human beings are experiencing is fundamentally their inability to be treated as human beings, and care plans that don't address how their well-being can still be addressed as the primary goal of their care plan, because everything is focusing on triggers, settings, and biological interventions with medication. A very brief review, and only very brief, of Dr. Power's approach and the scholars I've looked at to teach the residents how to identify preferences will show that the day-to-day preferences that patients have are fundamentally based on aging theory. And I just wanted to give you two summary ideas. One of the domains of aging theory look at identity, connectedness, security, autonomy, meaning, and joy. And if you look at many different scholars, and the one I looked at was Erickson, Dr. Powers looked at 3 or 4 others, all of their work seems to have these 5 to 7 categories. In another group that I've worked at with Dr. Erickson's work, both Eric and his wife, Joan Erickson, it's not rocket science. They did this work in the late 1940s. And they identified these skills as fundamental to older adults: resiliency, mastery, interdependency, a sense of agency, meaning, and purpose. You can see that there's a lot of similarity, so that aging theory is giving us the direction that our care plan ought to be thinking about for each patient with dementia. What are they doing to maintain their resiliency, their mastery, their emotional interaction with others, their sense of agency? I'll just give you a very simple example, which I don't even have on a slide. If a woman says she wants to comb her hair, she's telling us that that means a lot to her for her sense of resiliency, that despite her cognitive impairment, she still has a sense of beauty, of self-worth, of mastery over her functional care, that she wants to look good for others because of her interdependency with other human beings, her sense of agency that she can still learn how to hold a comb and do that. If you have someone come in and say, there now, let's get you all prepared for your meal, we'll do that for you, you're stripping her. Despite your good intentions, you might be stripping her. And if it's a struggle for her to do that, and the staff is really busy to get those meals out, there may be a lot of pressure just to wheel her out there and do it for her, or just to wheel her out here without the hair even being combed. So you can see that a very simple task, underneath that simple task, these very fundamental goals for human beings may be creating the foundation for how we reassess and determine what the care plan can be prioritizing. It doesn't mean we're ignoring her agitation when she throws the comb on the ground or when she hits someone who tries to comb her. But if we understand that beneath those behaviors are some fundamental goals for all human beings to have these tasks accomplished at the end of life, it might help us to redesign her day-to-day care planning. So let's look at what are the elements of a person-based care that's using the 4M model. First, if we're implementing this for the team, we want a program that's going to look at what is function-based. What do they do? How do they live? What are their values? What are their preferences? Have we identified what their preferences are by interviewing them? And more importantly, in memory units, have we interviewed their significant others, family, friends, to find out what is their story? What is their preference? And then translate that into their preferences. There are tools that are now doing this, but I'm not going to go into those today. I just want to highlight the philosophy. The social environment. How does the staff promote those preferences? How do they organize the day-to-day, week-to-week, and month-to-month care planning so that those preferences can be integrated into the care plan of our teams, which we know are minimum and low-wage workers with a great deal of turnover and not a lot of training in geriatrics. The work strategies. How are we organizing those teams? The care planning. How is the integration of this information with your lead experts, integrated into the work your frontline staff are doing, and then will it really improve their dignity and personhood? If we look at the whole system, what Dr. Resnick highlighted is that for many of our staff and our frontline staff, just giving them the information is like one ear and out the other. They have so many things to do. Unless we change their belief system, they won't be able to absorb a lot of this information. But to change the belief system, we need champions, and we're going to have leadership at the top of our institutions. That means that you, the management, your leadership, the medical leadership, the physicians and nurse practitioners, the lead nurses, the DNS, staff and families need to be aware of what you're attempting and have buy-in, and that leaders be identified from these groups. And if you're going to do it, we're going to have to look at how do you create support, rewards, promotion, recognition for the staff that are doing this, because this is beyond the basic interventions that people are taught to provide for medical care. That means eventually there will need to be policies, which we'll talk about towards the end. How do we change culture? How do we create these teams? Well, I already pointed out the most important thing is you. You're going to have to model that for other people and believe that this is really something you care about for your residents that have dementia problems, because you know that intuitively it's going to improve the dignity and care that they receive. So you have to have a vision that you can set forward, or that you have your medical leadership and nursing leadership set forward. But the most important piece that I found isn't even having your buy-in or your leadership. There needs to be champions identified in the workforce. And the most important thing I've learned over 40 years, and I found that Dr. Resnick from her research work agreed, is that it's discipline to discipline specific. The aides need an aide champion. The nurses need a nurse champion. Families need a family champion. The doctors are going to need a doctor champion. And you, for your board, or your investors, you're going to need to be the management champion. So at each level, you need to identify someone that really cares about this approach. And that core group should be trained first, because without a core group of champions, you've got a wheel without a center, and the spokes are going to come off. So you need to create a process, and it may take a long time. So this is not a sudden thing, and that's what we'll be talking about. Your system of change, like QAPI, starts at the core with a set of champions who can facilitate this model and buy into it. Let's move ahead. Here is another way to look at how the difference in leadership in the team and the way the teams work can operate. On the left is our traditional medical model. We've all been taught that this is really how an excellent program operates. And yet, if we're going to create a person-centered care model, the sense of agency needs to run through the whole organization. So instead of having every decision made by an expert, the staff needs to start learning how to make shared decision-making. This is not an easy skill. I understand that. And there'll need to be more training programs on how to do that. But right now, in terms of philosophy, to do this program, the champions need to be working with their tools in the care plan to show the staff how a shared decision-making can occur. Instead of seeing your team as an institution, it becomes a community. Instead of treatments, there's activities. Instead of focusing on outcomes, the highlight is the process. There's collaboration instead of control. There's interdependence. Death is not seen as a failure, something to avoid, but because it's a community, we understand that suffering and death may be part of our community. And the rituals are not those of submission to the disease and an ongoing sense of depression and loss, but rituals of celebration as human beings continue to make efforts to identify their preferences and find meaning in their lives despite their cognitive impairment. We don't punish the staff for mistakes. We realize we're trying to do something different, and there needs to be a culture that's a little more lenient and forgiving. I just want to come back here. There we go. So a nice summary is to model person-centered care, you have to demonstrate it with each other. That's the key piece of teamwork we're looking at in these communities. It may be necessary to train the staff in person-centered care and the 4 M's, to have the tools, to have nurses trained that can implement the tools, implement the strategies, and work with the families. But it's not sufficient unless the staff themselves are treating each other with these principles. So that to empower our residents, we need to learn how to empower each other if we're going to move from being a medical institution to more of a community. Choice then becomes something that the staff understands is what's built into the entire care plan, and those relationships then can focus on the well-being of the resident, not implementing a treatment to reduce the symptom, but even if they're treating the patient with a medical intervention, they're concerned about how are they maintaining their friendship, their care, and a response that maintains that person's preference. If that person only likes to be called honey by her husband, who's now dead, and she can't remember, and she doesn't like other women coming into the room, how can we have a male aide say, honey, I need you to come eat? It may seem phony, but that little preference, the family may tell you, is critical to getting her out of the room and into the cafeteria where she eats. Having 3 or 4 people come into the room when she's lived with one man for 62 years may be, in her mind, a frightening invasion. No matter how loving and gentle and respectful the staff are, she's going to be terrified. Why are these people coming into my room to take my blood pressure? Only my husband did that for the last 20 years of my life. Understanding that, rather than saying, oh, she's just going to have to get over it, is what, in a very simple way, person-centered care may be all about when it comes down to what matters. So that we have to see that in the end, our units are more of a laboratory for both team development and person-centered care, and not institutions that are providing fixed outcomes for the survey team.
You have one question in chat.
Okay.
2 minutes.
So lastly, we want to assemble your team. You're going to want to record your observations, ensure that the person is well known and that their preferences are identified, and that the care plan in some way integrates those preferences into their care plan program. I think I'll just maybe just put this up there. This is giving a little foreshadowing as we talk about what it would look like on your unit, but these are some of the basic skills that I've seen from Dr. Power's work and Dr. Resnick's work, kind of like a 10 commandments of if we could be doing even these things with our medical care, we'd be moving more towards a preference-based, person-centered model. You know, minimizing distractions, go low, go slow, using their name, be gentle. You can easily see that we could spend an hour talking about each of these interventions, keeping it simple. They often say, go from below, not from above with your hands. Don't go at someone, but offer yourself from below, not interrupting, repeating simple words rather than trying to explain yourself over and over again, and always never trying to empower someone by overpowering them. And lastly, I just listed a few from my own studies of programs that are doing person-centered work. The HALT study has been presented in the literature, which is not even a complete model, but you might want to look at that because they did identify how to have criteria to reduce neuroleptic drugs on a systematic basis and integrate initial principles into a traditional large memory unit. And of course, the other programs, Live Oak, Greenhouse, Household Wellspring, and the Eden programs are well known to many of us in gerontology who integrate person-centered care to the entire community. And here's our references. Okay, thank you.
Thank you, Dr. Krulewitch.
Thank you very much, Dr. Krulewitch. We really appreciate all this great information. I've opened up chat for any questions that folks may have, so please go ahead and enter your questions in chat, or you're also able to do that if you'd like to raise your hand to ask it verbally. Just let us know and Kelly can unmute you. So just kind of going off of what we already have in chat, we had Jeff that asked, is connectedness and interdependency basically the same thing?
Yes, it is. Connectedness has to do with both appreciating I call it the patient, but even I'm learning the person's emotional needs and the needs of the staff and family that are interacting with them. So yes, rather than seeing them as just focusing on their emotional state or the staff state, I look at interconnectedness as the enriching interaction and experience of two human beings in a relationship together, rather than seeing one as being dependent on the other. I think we forget that we perhaps gain a lot caring for our patients and helping the staff to realize that there's gifts involved, and that it's a privilege to be serving, and to see it as something that we can gain from them is something I try to remind the physicians, so they don't just feel that they're giving but not getting. And certainly I think our families appreciate to some extent. So the simple answer is yes. Interconnectedness is the same as interdependency.
Great, thank you. We had a question from Margaret about, are there training programs that you recommend for changing staff perception and behaviors in care? And Leah has entered a couple of ideas in chat, but Dr. K, if you'd like to
repeat the question, are there
Training programs.
training programs?
I recommended TPSNOS,
Yes.
Work, PAC, and Humanitudes.
Yeah, I think that most of us have been looking, TPSNOS work is what they're using with Dr. Resnick's model. And if you go to the EIT4 BPSD, the Nursing Home Toolkit, they've got a tremendous amount of resources there. You can also look up TPSNO, and she has a whole website herself with her materials. Her program is called DICE, D-I-C-E, and it's a way of breaking down the assessment. And then she has what's called the GEM model, where she breaks down the assessment by levels of dementia. And she has tools and toolkits to integrate that into the care plan, so that based on the level of impairment, one dementia patient might still be able to respond to communication with more dialogue, whereas another person who's more aphasic and having verbal difficulty may need a different intervention that's more physical with icons and symbols. So I would look at TPSNO's work. I don't have her website, but maybe that's something we need to get people.
Yeah. And actually,
go ahead.
TPSNO, a couple of her videos, I think, are also available through the Nursing Home Quality Improvement Campaign. So that's something that if you'd like more information on, please go ahead and reach out to your state lead, and they can get you some links to training and resources.
And the Nursing Home Toolkit and the EIT, they have extensive bibliographies and toolkits from many different universities. That's why I listed those, because those are rather significant websites.
Wonderful. So given that we're a little bit over, I just wanted to open it up to any final questions. We did have a comment to my question that was posed about what person-centered practices people are already using. And we did have Kathy mention that they do ask on admission about resident preferences for all aspects of daily life and what's important for them to continue. So great practice. And if they can't answer, they bring this information out through the family. So just a couple more seconds for any final questions that we have.
I would just remind people it's a very slow process. Starts slow, small. Like we say in medications, go low, go slow. In the homes that I've started this, we picked just 5 of the most difficult patients with the pharmacist, patients on the most amount of drugs and the least amount of tapered doses documented. And we're picking just our real complex cases, and we're working with our champions to work on those 5 to see how we can begin to do this. And we're going to spend 6 months to a year. We're going to go very slow so we can convince our executive management teams we're not wasting resources and educational resources, because we understand the very severe limitations that our institutions are under to train and provide programs that require more labor and education from frontline troops.
Wonderful. Well, I want to make a couple announcements before we conclude. Number one being that this presentation will be posted to our website in a few weeks, and I encourage you to check out all of our posted webinars there on our nursing home library. The link's been posted into chat. Please share this with any of your colleagues who couldn't attend today, or feel free to use it to in-service your staff. For CEs, again, New Mexico teams, please make sure I've got the name and email of all attendees in chat, or you can email me after, so we can send you a test link early next week. And please join us on June 14th for our next hot topic, which will be a part 2 of our dementia-related agitation presentation with Dr. John Donaldson, who was our presenter in March. I'd like to thank everybody else who was in attendance today. Thank you for coming to Hot Topics, and going to release you back to your day. So happy Friday, and this is the conclusion of our webinar.